Next session is by Dr. Raviteja Innamuri. The topic is promising biomarkers for predicting, monitoring, and measuring treatment response. Now I invite Chairperson Dr. ANANDA KRISHNA sir. Sir had done his undergraduation PhD Institute and Medical Sciences Research, Coimbatore. He had done post-graduation from Madurai Medical College, Madurai. Sir is working as Professor of Psychiatry at THENI Medical College. He is having 15 years of undergraduate teachership experience and 12 years of postgraduate teachership experience. His areas of interest are organic psychiatry, licensed psychiatry, and forensic psychiatry. Now I request Ananda Krishna sir to take over the session. Thank you, sir.
Good morning, all of you. First of all, I thank the IPS House Zone office bearers and CME committee members for permitting me to chair the session. My special thanks to Dr. V.K. Arvind, CME chairman, for giving him this opportunity. So the current topic is going to be given by another young speaker, promising biomarkers for predicting, monitoring, and measuring treatment response. Basically, biological markers are interesting and challenging field for psychiatrists. Biological markers are basically measurable indicators. They are measurable not only in a normal biological process, also in a pathophysiological state, as well as treatment monitoring states. There are various biological markers have been described, which this speaker is going to give: susceptibility markers, predictive markers, diagnostic markers, trait markers, and also monitoring markers. Biological markers are not basically clinical symptoms. They are measurable, which are reproducible, as well as having high sensitivity and specificity. There are a lot of omics technology, as we know, say for genomics or proteomics or transcriptomics. These all omics technology will help in developing certain biological markers so that they may give a promising tool for diagnosis as well as treatment monitoring. We are living in an era of precision medicine and heading towards a personalized medicine, where these biological markers are definitely going to help in even redefine the classification of psychiatric illness. For example, a neuroinflammatory markers have been described for depression, where CRP levels or certain tumor necrosis alpha or interleukins, they are helpful even in diagnosing, assessing severity, as well as treatment response in depression. Basically, they are measurable markers. If possible, practically, if you develop certain peripheral markers, which has non-invasive as well as cost-effective, they will be helpful definitely in identification of illness early, in fact, even prevention of psychiatric illness, as well as treatment progression. With this brief introduction, I introduce the speaker, Dr. Raviteja Innamuri. He is the Assistant Professor of Psychiatry at Government Medical College, Nizamabad. He holds the DPM, DNB, as well as MD Psychiatry from CMC Vellore, and has done his post-graduation diploma in medical law from National School of Bangalore. He enjoys teaching and believes in holistic patient care. This brief introduction, I hand over the mic to the speaker, Dr. Raviteja.
You are not audible, Raviteja.
Kindly unmute, sir.
My humble pranam to the chairperson, respected seniors, and admirable colleagues. After that, 2 wonderful lectures, I wouldn't mind, with the permission of the organizing committee, if all of you would like to take a break for a minute or two to do some deep breathing so that you're able to replenish your neurotransmitters and have the correlated discharges in place. Thank you, sir. You made my work really easy because you actually summarized the whole of the lecture in a few sentences. And with that, we begin this topic for today, which is promising biomarkers for predicting, monitoring, and measuring treatment response. Otherwise, what I would simply call, do we have a test in psychiatry yet? Now, to understand or to predict the future, well, what I know is to understand the present and see what has happened in the past. Because what famous psychiatrist Nasir Gemi says, that no other branch of medicine has revolutionized itself every 50 years. And psychiatry continues to see it. For that, we reflect on the current scenario is how we were trained as doctors with MBBS, and how we changed as specialist psychiatrists. My uncle, Raghu, who is a 40-year-old businessman, reported with abdominal pain and vomiting. I quickly rushed him to the nearest super specialty hospital, where with colleagues we made differential diagnosis of food poisoning, cholecystitis, pancreatitis, acid peptic disease, hepatitis, appendicitis, etc., etc. But within a few hours, we understood that the blood counts were raised and an ultrasound abdomen and pelvis confirmed inflamed appendix. Management was planned, and within a few days, my uncle walked out of the hospital perfectly okay. This is a perfect example of how biomarkers play a magnanimous role in the management of any clinical condition. Here, simply the biomarkers were laced counts, which shows infection and inflammatory changes of the appendix that was revealed by the ultrasonography. A few years later into specialist training, few weeks back ago, I had Mr. Rohit who had come to the OPD. And it's not unusual. They walk in with a huge bunch of files and opinions from various psychiatrists and institutions. Mr. Rohit had a very difficult timeline of events. At 12 years of age, he had difficulty concentration. And fortunately, he went to a good school. He had a counselor who referred to a psychiatrist and was diagnosed with ADHD and was given treatment for it. But by 15 years of age, he got into bad company, had been diagnosed with substance use disorders, had to stay for a few months in a rehab facility in Hyderabad at a young age. But by 17, when parents thought he would like get into some groove and start focusing on things, then realized that he was anxious most of the time, feeling low most of the time, and he was diagnosed with a depressive disorder. By 21 years, he was cutting himself, he had mood swings, and he was diagnosed with perhaps a bipolar disorder. But by the time he had come to us, he was 24, and he reported of confused thoughts, abnormal behavior, and memory problems, which the recent visit was gave an unconfirmatory tentative diagnosis of schizophrenia. Now, Mr. Rohit asks us, is there any way we could help give a clear-cut diagnosis as what is he suffering with? What is the treatment for that particular condition? And as and we are at a loss of words because we know that the current care pathway, and when we reflect on it, we take the complaints, the history of presenting illness, the significant history, the past treatment history, we look at the mental status examination, we formulate as per the ICD-DSM, and we have standard guidelines, and through trial and error method, we have to wait for a few weeks to say whether that particular drug or technique is working or not, to either augment or change. And we know that with context in life, and we expect a very dynamic course of this diagnosis. And to complicate the scenario overall, we have so many heterogeneous symptoms under a single diagnosis. And the same diagnosis, you could have different patients with the same diagnosis and they all present differently, something that we really enjoy in clinical practice, but is a nightmare when it comes to being very confident about diagnosis and management. At the same time, when we think of management, you have the same medication that we use for different diagnoses, and the same diagnosis could have different medications as treatment protocol. Even after we take a step further, we see really disappointing results from real world studies, wherein in KT you had nearly 3/4 of the sample that discontinued treatment within an year and a half of trial. In STAR-D, only 31 responded to the first antidepressant. And in bipolar, lithium, which is the first line, only 30% respond to it. So for a while now, we have been taking symptom descriptions, we are making them into syndromes and then mapping them into ICD-DSM. The diagnoses, which are reliable but not valid. But there is nothing to be really disappointed about, because this is much was the history of medicine. Well, I would say we closely thread the history of what cancer is offering us. Because if we look into what Galen first spoke about, the humoral theory, and then he said, largely all diseases are an imbalance of these humors. He said black bile was responsible for two conditions. One was cancer and another was depression. And few years later, when Vesalius was secretly smuggling these dead bodies into his lab and cutting open, and he found all the green, white, red, all the biles, but he couldn't find black bile, he was he, instead of saying it didn't exist, he rather said Galen is such a great man that he could hypothesize something that I can't see despite cutting all the organs and the bodies open. And this is remaining as an enigma for cancer as well as psychiatry. But what is more promising as that Siddhartha Mukherjee, who describes the history of cancer and what cancer is all in the current state, writes about psychosis, writes about psychiatric disorders, and writes about the advances that genomic medicine is making to offer answers to us like the way it answered in cancer. Why? Because much like in the history of psychiatry, largely whenever a conference happened in cancer, these groups divided themselves into two groups. One that discussed about the genes that were responsible for various cancers, and another that talked about chemotherapy cocktails, how to treat them. Until one drug was introduced that was specifically made to target a particular gene, which was trastuzumab, which is a monoclonal antibody for HER2 receptor positive cancer. And here, what if, and I pause and ask, what if we had a monoclonal antibody for BRD1 gene? Then what if we had a possibility to diagnose our psychological disorders? What if there's a possibility of predicting response to a certain drug instead of waiting for certain weeks? And this is where we usher a world of precision medicine, individualized medicine, or personalized medicine. And this is where biomarkers come into picture. Like Professor was saying, these are measurable characteristics, indicator of normal or pathological processes that or responses to a particular intervention. You have various kinds of biomarkers, and for theoretical purposes, they have been differentiated, but you see that more or less they are linked to one another and they have overlapping functions. You have diagnostic biomarkers, which confirm or detect the presence of a disease or identify subtypes like, levels of A beta 42 or T tau in CSF with patients with dementia. You have monitoring. The simplest example that we give is monitoring potassium or creatinine levels in medicine wards. Psychodynamic is somewhat a monitoring for a particular drug that helps you to understand should you use or discontinue use of a particular drug. Predictive is more or less the end result. What if I have used olanzapine for schizophrenia? Well, that the patient will respond to it or not. We have identified certain specific SNPs here. There are prognostic that talks about even more longitudinal course of disease severity, disease recurrence, relapses, hospitalization. Good case in point is the trinucleotide CAG repetitions in Huntington's. Safety that talks about the probability of a toxicity of a drug or an adverse event. Here we have CYP2D6 genes that modify risperidone metabolism, or the susceptibility or risk that talks about what are the chances that my child would have schizophrenia, or a patient would ask such a question. And we always offer probabilities. Perhaps we'll be able to more confidently talk about using IL-6 and CRP levels. Like Sir was saying, there are two types to this. One is a central biomarker, the one that has become quite popular in the last 2 decades with the advent of functional neuroimaging. And if you take a functional MRI as an example, there are various pros because you could measure the cerebral blood flow changes, the energy metabolism, the neurotransmitter receptor density, while the costs are the high cost, the limited access, and which is huge for a developing country like us. And you have peripheral biomarkers, which are very easy to collect. They have as we understand the relationship with CNS, especially through cytokines, the mediation of cytokines, which modify the endo behavioral responses. We tend to we can utilize it as an easier tool, and that's why perhaps Sir was saying we should venture more into lymphocytes and other peripheral biomarkers. Well, we look into any branch of medicine, or we look into medicine as a whole. If we were to predict what would the next biggest breakthroughs, we would actually have to go into the research and developmental wing and see what this biotechnology, bioinformatics chaps are doing. And look at radiology, for an example. A generation ago, my parents never wanted to choose radiology. Now, in this generation, this is the most sought after branch only because of the technology breakthroughs that this imaging has offered. Much like these technologies that are emerging are what are going to redefine what psychiatry would be in a generation or two. And these technologies are genomic medicine. Well, again, for the sake of reason, because we don't usually look at these in our day-to-day life, you have the genome, the complete information across generations, and then you have chromosomes, you unwind them, you have the genes, and you have nucleotides and nucleosides, and if much more or less the genome of every human being is very similar, but you have these variations in the single nucleotide polymorphism, which we call SNPs. And these variations, when compared with the deceased and the non-deceased, and we look at these polymorphisms as associations to be able to predict and personalize these medication. Of course, these are measurable DNA or RNA characteristics that help us understand in disease pathogenesis. But so we have various ways to study them. We have various techniques that have been developed that are that made us very recently in May 2021. We could say that we have coded the entire human genome and the successful completion of the Human Genome Project. But unfortunately, we didn't have much answers. Well, I should have said that much sadly, perhaps. But the reason was that they could not clearly say this. They could not identify candidate gene. They could not identify clear, very SNPs with high penetrance. So a case, an example is, say, autism. Less than 3 in 100 cases of autism have clear de novo mutations with high impact, like say Fragile X with FMR1 gene. Most of these 97 cases have various SNPs that we do not know are working as a network, or we do not know with each generation there's an accumulation of these variants, and however they have this low penetrance that present in that particular patient. So you have polygenic many genes causing a particular disease, and at the same time you have pleiotropy, the same gene, say DISC1, NRG1, CACNA1C, which are responsible for various psychiatric disorders. So, and these are varying with geography, these are varying with race, and well, but still, we do have various genomic markers that tell us about predisposition, response, severity for all the psychiatric disorders. But so we thought, what if there are multiple genes? These multiple genes must be producing similar RNA, which perhaps are more closer to the disease. And then we began to study this RNA, what brought us this transcriptomic biomarkers. Various techniques, again, microarrays and RNA sequences, but perhaps this is more dynamic and is thought to reflect cellular state better than the DNA data. Again, here we have various kinds of biomarkers to predict efficacy, risk, response for all psychiatric disorders. Then we thought, why stick to RNA if you could go a step ahead and look at the proteins which the RNA is making, because they're more closer to the disease. And therein, we began to identify various proteins like zinc finger 729, acetyl L-carnitine. And then again, we have various utilities of these proteomic biomarkers. Finally, well, as you must have already guessed, the next that comes are metabolites from these proteins, which are what brought this technology of metabolomics biomarkers, which are way more dynamic, way more time sensitive, and using techniques of mass spectroscopy, we are able to identify them for various disorders. Well, last but not the least, we cannot get away without mentioning this epigenetic biomarkers, which perhaps are one of the key ways which explain why disorders or psychological problems that are not seen for generations as a whole are suddenly manifesting in a single generation. What we may get away by saying karma, people of genomic medicine will call this epigenetics, which are the dynamic variations in the gene structure, modifying gene expression without changing the sequence of the DNA. Well, a good short notes, which we all won't forget. Well, we also need to acknowledge the current technologies which we are largely studying, which especially imaging. We are using various functional imaging and various methods to see how are comparing between the responders and not responders. But honestly, it is a great promise not kept, but in correlation with this may give us extraordinary information. Similarly, somebody was asking about EEG, and Professor Venkat had beautifully answered. Well, what now for psychiatric disorders, what I have understood is, we are not just looking at the visual inspection of these physiological electric currents. We are looking at quantitative EEG using computational information algorithms that talk about quantitative EEG data, which much better reflect on various functional attributes. Say, for example, Sir was talking about frequency oscillations. Another such as cadence, which talks about, which is an equivalent of how much cerebral blood flow a particular part of the brain is receiving. We have amazing number of studies being done. This is being commercially promoted as a brain map, but as of now, we don't have a single established biomarker of any EEG correlate. Well, I know that we are a bit short of time, but well, I may have already disappointed you enough, but to bring some optimism into the talk, I will quickly run through what are the current promising biomarkers for each of the major criteria disorders, except addiction, the substance use disorders, which Dr. Namita would anyway be talking after me. So bipolar disorders, we have clinical data, which we should not forget how these clinical data points become still a very important point in predicting responses. So we have this data for each medicine, which a drug. So now we very well know about lithium. We talk about lower BMI, family history of bipolar type 1, MDI type pattern, high age illness onset, high scores on this temperament scales, and hyperthymic temperament. Similarly, we have associations, positive, negative, as ambivalent associations with various SNPs. We also have data from neuroimaging and others, like we were talking about positive emission graphy that gives us differential cerebral brain flow patterns in rostral anterior cingulate, DLPFC in lithium and valproate responders, differential excitability of neurons seen in EEG, and thyroid functions. For major depressive disorders, again, we have clinical data points for SSRIs are here. And very interestingly, if you notice, even under the same class, different drugs have different indicators. This is not just with clinical data. You have SNPs that show the same. You have imaging that show the same. For sertraline responders, it's hippocampal connectivity. For fluoxetine, it is greater anterior cingulate cortex activation. For bupropion, cerebellar hypometabolism. And even for behavioral therapy, we have different indicators. Well, but I have noticed that for depressive disorders in particular, the evidence is also quite strong, and we have various proprietary formulations wherein they're able to use complex algorithms like antidepressant treatment response and to be able to predict responses for antidepressants. For schizophrenia and other psychotic disorders, we have we have a good response to antipsychotics with positive negative symptoms, early responders, and living with a partner. We have for each antipsychotic, we have a positive correlations for positive symptoms, negative symptoms as well. Imaging talking largely about the high dopamine receptor occupancy. And for autism spectrum disorders, only risperidone and aripiprazole are FDA approved. And there is decent enough but not good enough data that talks about indicators for good response in risperidone, which is largely high parent education level, higher income, lower baseline prolactin, higher baseline ABC irritability score. Various polymorphism, but not only for response, but also we talk about how much weight gain or weight circums would be influenced by this. And this is both this is not just we have the RNA data from the transcriptomics as well. Now, what is predicted to happen? This current care pathway that we first saw in this in the initial slide will transform to this. That with these emerging technologies, we would use the clinical data and overlap with this various information that we would derive from EEG, transcriptomics, genomics, morphology, advanced computational algorithms. And we know this, that artificial intelligence is making leaps and bounds on a day-to-day basis. And we have advanced machine learning and deep learning tools that will take this forward. And what we can hope in the future, in a generation or two, is give us way more easier methods to be able to predict responses for our patients and clients. Well, the challenges are very clear. This is going to be a very lengthy, complex, with a lot of ethical and legal challenges. But if we are believing in technology, like we are doing this today over a Zoom platform, that was perhaps not imagined a few years ago. So we have various informatic tools and a plethora of information and a lot of algorithms that are emerging, which will give us treatment options with a list of preferences. And perhaps each of us seem very, a lot of us may seem disconnected with it, because it seems, again, like in the history of cancer, that only a specific set are talking about this neurobiology or advances, which is the fourth paper for our MD, but we don't really talk about it much once we get into clinical practice, especially private practitioners. But we all can give a lot of data to supplement, augment it, and we hope collaborations will make that possible. Now, to conclude, we have to say that we are in the beginning phases. They will be a method wherein we are going to integrate all these possible sources to generate reliable and valid data. And more importantly, is that currently even NIH is funding only studies that are adopting the RDoC criteria. Now, if you look into this, what I have noticed is, like I was highlighting as we went about slide by slide, that these data was different for different classes of drugs. It is different for the same drugs in the different drugs of the same class. It is many correlates seem very similar for different psychiatric disorders. They're all talking about cortical atrophy, enlarged ventricles, similar neurotransmitters. And so what the current data is talking about, which is a bit beyond the scope of this current talk, is that we are not the data that we are finding is not matching with the clinical diagnostic criteria that we are using. And it is revealing to us these biotypes that are quite different from this clinical categorization, that talk about symptoms, the positive, negative valences, and talk about neurophysiological correlates that are different from each biotype, each brain. With that, I would like to conclude my lecture, and these are my references. I would like to once again thank the organizers, especially Professor Dr. KRISHNA sir, for inviting and giving me this opportunity, Dr. Arvind sir, Dr. Anto Rajmani from the Institute of Mental Health, Nottingham, who made it a bit comprehensible as I was overwhelmed with such a large number of papers and studies, the IPS and Linux laboratories for making this possible. Thank you so much.
Thank you, Dr. Raviteja, for giving a wonderful and lucid presentation. And you have almost summarized based on the current literature about including recent advances.
Thank you, sir.
Currently, the topic is open for discussion. Any questions?
Sir,
If there are
there
no
is no.
questions, we can just go roll on to the next session and we can go at the end of the session for question and answers.
Okay, sir. Thank you for a presentation by the speaker. And suppose if you have a lot of electrophysiological plus EEG based as well as peripheral based biomarkers if available, we'll have a promising future in relation to treatment of psychiatric disorders. We can minimize the non-response as well as treatment resistance. With this, I thank all the organizers for giving this opportunity. Let us move on to the next lecture. Thank you.
Thank you, sir.